Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to today's call, Surveillance News You Can Use, NHSN Updates for 2015. All lines have been placed on listen-only mode, and the floor will be open for your questions later in the call. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Dept Smith. Dept, the floor is yours.
Thank you, Erin. As Erin mentioned, my name is Dept Smith, and on behalf of VHQC, I'd like to welcome you to today's webinar, Surveillance News You Can Use, outlining the NHSN updates for 2015, which we know 2015 is going to be here before we know it. I'd also like to mention that this webinar is being conducted in partnership with VHQC, Virginia APIC, Virginia Department of Health, Maryland Healthcare Commission, and the Maryland Department of Health and Mental Hygiene. We've opened this up to providers in both Maryland and Virginia. Supporting patient and family engagement in healthcare decisions is an important goal for all of us. So future webinars will include patient advocates on the agenda. With the tight schedule today and the holidays coming, we were unable to coordinate with a patient advocate for this webinar. Before we get started, I'd like to ask a question to determine who our audience is. So Erin, please post the polling question now. I'm sorry, Jennifer, could you please post the polling question now? You'll see the question pop up on the right-hand side of your screen. If you do not see your profession here, though, please write it in the chat box. You can access the chat box by clicking the chat icon in the upper right-hand corner of your screen. While we're waiting for the polling results, I would like to go over a few housekeeping items with you. First, today's session will be recorded, and the recording will be emailed to you and also available on VHQC's website within 7 days. Also, we want this session to be interactive, so please participate by answering any questions asked either in the polling function or in the chat box. We do have a tight schedule today, so there may not be much time at the end of the webinar for questions. So please use the chat box during the webinar to ask questions. If we cannot address them today, we will follow up with you after the webinar. Carol Whalen, the improvement consultant working with VHQC in Maryland, will be monitoring the chat box for us today. Carol, do you have the results of the polling questions yet?
Hello, Deb and everyone. I'm not seeing the results list. I think we have about we should be popping up at any moment here. It says remaining time 0, so.
Well, let me introduce today's speakers, and then we'll come back to that. So today on the line, we have Andrea Alvarez from Virginia Department of Health, Sherry Merricks and Marcia Kemp from Virginia APIC, Katie Richards from the Maryland Department of Health and Mental Hygiene, Teresa Lee and Eileen Witherspoon from the Maryland Healthcare Commission, and I'm Dept Smith from VHQC. So, Carol, do you have those results yet?
Yes, we have them now. So it looks like we have about 39 out of 64 infection preventionists on the call today. We have 2 quality improvement professionals out of 64. It doesn't look like we have any analysts or any IT people on the call, and we have 1 other. I just checked in the chat box. I didn't see what the 1 other was, but it looks like those are the results that we have, and about 22 with no answer.
All right. Thank you, Carol.
You're welcome. Okay. It looks like, Deb,
go ahead.
It looks like somebody may have got kicked off before they could vote, but they're an IT.
Awesome.
Okay.
So welcome, everybody. And just as a reminder, this webinar is being recorded, and it will be available at least maybe around 7 days after it's finished. So our objectives for today are to notify IPs and anybody else working with NHSN of the 2015 changes that are coming. We're going to be having an overview of the changes to surveillance definition, data collecting, mapping units, and the annual survey. And then at the end, we'll have updates from Virginia APIC, VDH, Maryland Department of Health and Mental Hygiene, from the Maryland Healthcare Commission and DHQC. So without further ado, I would like to introduce Andrea Alvarez, the HAI and Influenza Program Coordinator for the Virginia Department of Health. Welcome, Andrea, and I will now turn the program over to you.
Thank you, Deb. This is Andrea. I'll start by talking about the purpose behind the changes for 2015. As you may have already noticed, they are substantial and very important. And this year is critical because 2015 will serve as the new baseline year for standardized infection ratio calculations going forward. So we need to standardize our surveillance and make sure that we're applying the definitions appropriately. These definitions should decrease the subjectivity, improve data collection and entry practices, and better simplify, align criteria and definitions going forward. So we hope that they are beneficial to you. Next slide, please. And then just taking a peek beyond 2015, CDC has said that there are no near-term plans for revising the definitions and criteria beyond this, but of course it's always subject to change. Future changes are likely to be a result of increasing use of electronic health records and use of electronic data capture. And they anticipate in the next 3 to 5 years that we may move towards fully electronic capture of required data and determination of reported events. Next slide, please. A brief overview of some of the high-level changes. Sherry Merrick will be talking more specifically about mapping locations. But for the 2014-15 flu season for acute care hospitals, healthcare worker influenza vaccination summary data are now reported from personnel working in hospital outpatient departments, along with accounts from personnel working in inpatient locations. That's something a little bit different. And beginning January 1, 2015, CLABSI and CAUTI from all adult and pediatric medical, surgical, and medical surgical wards are to be reported as well. Another key thing to definitely print and have at your desk as resources are the updated Chapter 17 definitions. And these are the CDC NHSN surveillance definitions for specific types of infections. Some of these definitions haven't been updated in a significant manner since the late 1990s and were definitely out of date. So this particular chapter is definitely of great importance. So moving on to some of the updated or new key terms that you need to make sure you know and understand. The first is the infection window period. And this replaces the gap day that used to be part of the evaluation to determine whether the criteria were met in an appropriate time frame. So this new term, infection window, refers to the 7-day period during which all site-specific infection criteria must be met. This includes the day of the first positive diagnostic test, for example, the date of the last specimen was collected, the 3 calendar days before that, and the 3 calendar days after that. Now, of note, this term does not apply to SSI, ventilator-associated events, or lab ID events. The date of event term has also been revised. Prior to 2015, this referred to the date of the last element of the infection criteria. But for 2015 and moving forward, it's different. The date of event is the date of the first element of the infection criteria, and this must fall within that 7-day infection window period. This term does not apply to ventilator-associated events or lab ID event reporting. And like before, this date of event field is used in combination with other criteria to determine whether an infection is present on admission or considered a healthcare-associated infection, meaning on or after day 3. Another new term is the repeat infection timeframe, or RIT. This term does not apply to SSI, VAE, or lab ID events either. And this is implemented because there was some fuzziness and ambiguity regarding when an infection was a repeat and when it was a continuation of a prior infection. So this time frame is defined as the 14-day period during which repeat infections of the same type will not be reported to NHSN. If additional site-specific specimens are collected within this time frame and new pathogens are identified, those pathogens would be added to the original infection. So, for example, if you had a CLABSI that was E. coli, and then within the same 14-day window period, you had another blood culture that was positive for a different organism, that would not be a new infection. It would be a continuation of the same infection. Next slide, please. The secondary bloodstream infection attribution period is another quantitative period that's used to determine the time period during which a bloodstream infection can be attributed as secondary to another infection site. This length of period will vary from 14 to 17 days, and the 2015 protocol will go into more detail about this. But these are just high-level bullets to get you thinking about these terms and how to apply them. So this period includes the infection window period of the primary infection, as well as that infection's repeat infection time frame. And of note, this does not apply to SSI, VAE, or LAB-IG events. Next slide. Thank you, guys. A few other bloodstream infection surveillance definition changes of note. When applying the secondary bloodstream infection definition, you no longer need to determine if an organism is a, quote, logical pathogen for another specific site of infection. There are some differences for core temperatures that are applicable not just for bloodstream infections, but as you'll see for urinary tract infections as well. That core temperatures are no longer required to document infant fevers, and also the recommendation that you do not convert any temperatures based on the route in which it was taken, even if your hospital policy says to do so. One change for denominator data collection for CLABSI and CAUTI that hopefully will make your lives easier is an alternate method. And to be eligible to collect denominator data, the unit or units need to be in intensive care unit or board location with 75 or more device days per month. So unfortunately not applicable for the smaller facilities. But this alternate method requires data collection of patient days and device days on a single day each week, as well as collecting the total number of patient days for the month. So in your facility, you can choose, for example, Tuesdays is going to be your device day collection, your patient day collection. So every Tuesday, you collect that information. Now, of note, the traditional method, counting every day, is still available. This is just an alternate method that CDC has power tested and determined is appropriate for these units that have that eligible number of device days. Moving to cancer-associated urinary tract infections, UTIs in general. Only urine cultures with a colony count of at least 100,000 CFUs per milliliter for at least one bacteria will be used to meet NHSN UTI criteria. Change B, I think, will be of interest, and very much I look forward to this for a long time now. So only bacteria will be accepted as causative organisms. That means no yeast, mold, fungi, or parasites. So if you have a positive candida, no longer considered a UTI under the surveillance definition. There is a minor revision to the SUDI 1A criterion that the patient has to have the indwelling catheter in place for the entire day on the date of event, and the catheter had been in place for more than 2 calendar days. And as mentioned on a prior slide, there is a difference in how to calculate fever. Some of the ventilator-associated event changes of note. There are several more, but again, just some highlights. There's a new category called PVAP, which replaces the possible VAP and probable VAP. And there are 3 pathways to satisfy this definition. But in the interest of time, we don't have the appropriate time to dedicate to this. So I refer you to the definitions to learn more about that. Ventilator-associated event reporting will exclude pathogens that are typically acquired from the environment, and some examples include Cryptococcus, Blastomyces, and Pneumocystis. There's a new exception regarding the selection of daily minimum PEEP and SiO2 settings, and there are examples in the protocol of when this applies. And then there's a new optional denominator called episodes of mechanical ventilation. This is an optional denominator for VAE surveillance only, and ventilator days and APRV days will continue to be required denominators. For surgical site infections, there's a new variable called infection present at time of surgery. New acronym for you, PATOS. So this particular field does not apply if there's a period of wellness between the time of the preoperative condition and surgery. The infection must be noted preoperatively or found intraoperatively in a pre-op or intra-op note. And you select yes to this variable if it applies to the depth of surgical site infection that is attributed to the procedure. So there's some evaluation needed to see if it makes sense, determining on the depth of SSI. For SSIs that have this variable indicated as yes, they will be excluded from the SIRs for surgical site infections beginning with 2016 data. So these will be excluded from the denominator. For hip replacement surgery and knee replacement surgery revision procedures, if one of these types of procedures is performed, certain ICD-9 diagnoses or procedure codes should be evaluated to see if they were coded in the 90 days prior to and including the index hip replacement or knee replacement revision. And if yes, then there's a variable on the denominator form that should be checked. And that variable is was the revision associated with prior infection at index joint. This variable is important because it will be used as a new risk factor to be considered in risk adjustment for the 2015 baseline. 2 other changes of note with respect to surgical site infections: a change to how diabetes is defined, along with how it's currently defined in NHSN. The discharge ICD-9 codes listed on the slide are also acceptable to endorse that variable. Diabetes is yes. And then with the scope field, you should check yes if the operative procedure was coded as a laparoscopic procedure performed using a laparoscope or robotic assist. Next slide. For multi-drug-resistant organism and C. diff infection changes, there's some changes to the denominator reporting here. For facility-wide inpatient reporting, for 2015 and beyond, you would exclude inpatient locations that have a CCN that is different from the acute care facility. So this would include things like an inpatient rehab unit or an inpatient psych unit, because now they have their own separate reporting mechanisms. So they would be excluded from your facility-wide inpatient denominator reporting. Also, the MDRO CDI Lab ID event facility-wide inpatient reporting will also require location-specific surveillance for that organism, for example, C. diff, in each emergency department, and that includes pediatric or adults, EDs, and 24-hour observation locations. Specific to carbapenem-resistant Enterobacteriaceae, Enterobacter is added as an organism for CRE reporting. To do in-plan reporting for CRE, you must conduct surveillance on all 3 CRE organisms, that is Enterobacter, E. coli, and Klebsiella pneumoniae or Oxytoca. To be considered a CRE, carbapenem was added to the definition, and the definition now states that any E. coli, K. Oxytoca, or Enterobacter that's resistant to 1 or more carbapenems by susceptibility testing method, or that produces a carbapenemase demonstrated by a recognized test, such as a PCR or modified Hodge test, is a CRE. That's a little bit different from how it was previously. There are some new optional questions for Lab ID event, MDRO, or CDI reporting, and these were added to improve tracking through the continuum of care. These variables are last physical overnight location of patient immediately prior to arrival in the facility, and has the patient been discharged from another facility in the past 4 weeks. Previously, it had asked if the patient was discharged from your facility, but now it's adding in your knowledge of whether the patient has been in another facility. In addition, C. diff GI system infection has been added as a specific infection type, and this is for infection surveillance. This is not a Lab ID event reporting change. For our friends monitoring infections in LTACs and inpatient rehabilitation facilities, just a reminder that January 1 of 2015, facility-wide MRSA bacteremia and CDI Lab ID event data are required to be reported by these facilities and locations. This webinar, I hope, will be helpful to you, giving broad overviews of some of these definition changes, but we definitely want to refer you to other training resources. Currently on the CDC NHSN website, they've started to add some module-specific or hot topic trainings and online resources. The protocols have not yet been posted, but some of these module-specific trainings are. There is an in-person training in Atlanta in mid-February that also is available via web streaming, and those sessions are always recorded and are very rich and helpful. And then we also direct you to the September 2014 NHSN newsletter, where I pulled a lot of the information for these slides, and that goes into some more detail. So I'll now turn the floor back over to Deb to transition to our next speaker. Thank you.
Thank you, Andrea. That's all very interesting, and I'm sure everyone on the line is finding it interesting. But I'd like to ask our second polling question now. So, Jennifer, can you put up the second polling question? How prepared is your facility for the 2015 changes to NHSN surveillance and reporting, and including if you need to get any assistance from your IT department? While we're answering this question, I'm going to go ahead and introduce our next speaker for today, and then we'll go over this question after our next speaker is done. So our next speaker is Sherry Merrick. She's the current 2014 Virginia APIC president. She's a certified infection preventionist working at Carilion-Giles Memorial Hospital, and she'll be going over mapping locations in the annual survey. So, Sherry, the floor is yours.
Thank you, Deb. Good afternoon, everyone. Deb, can they hear me okay?
I can hear you very well.
Okay, good. Well, as we all know, January 1, 2015, we will begin expanded reporting of our CLABSIs and CAUTIs for our inpatient areas. In addition to ICU areas, we will be reporting CLABSI and CAUTI data from adult and pediatric medical, surgical, and of course our medical surgical areas. Next slide. The mapped or defined areas per CDC are, of course, the medical, the surgical, or med-surg, adult, and then the same for our pediatric areas. Okay. On this slide, I pulled information from the September 2014 NHSN newsletter, and this example was given for new areas to report. The adult wards are identified by location/population served, and you would notice that it's like it shows the IN for inpatient, acute, because it's an acute admission, ward, and then M for medical. And then I think the rest is pretty self-explanatory, except that the pediatric wards then are identified the same, but they have the abbreviation of PED at the end of it. Next slide. I know some facilities have utilized NHSN for reporting for all areas of their facilities in the past. Well, any area that is not an ICU or a NICU or one from the previous slides will not be required reporting in 2015. For example, orthopedics, telemetry, or PCUs. It is okay to continue to report these, however, this data will not be shared with CMS. So now we need to look at types of patients being served in each unit/ward at our respective facilities to determine the most appropriate CDC location title for it. To set up mapping in NHSN, you'd want to follow the instructions for mapping patient care locations in NHSN, which can be found on the NHSN website. This is referenced on this slide and on our last slide for your convenience. These instructions are from January 2014. The instructions provide an algorithm to help you identify which areas to set up in NHSN for reporting. This algorithm should also be used whenever you add a new unit or when a unit has undergone changes in the patient mix, for example, for NHSN surveillance reporting. Okay, this document provides information for patient mix, and I want to go ahead and tell you a little bit about each of these four titles. Patient mix is when we need to review the patient mix in that unit for the last full calendar year, and if a full year is not available, the facility should review patient mix based on data they have available for that unit. For the NHSN 80% rule, it's basically if 80% of patients are of a certain type, like pediatric patients with orthopedic problems, for example, then that area is designated as that type of location. So you put, in this case, you put an inpatient pediatric orthopedic ward. And of course, remember, PED would be at the end. And then the next item mentioned is virtual locations. Well, they define this as when a facility is unable to meet the 80% rule for location designation in a single physical unit, but would like to report their NHSN data for each of the major specific patient types in that unit. Virtual locations is recommended only for those physical units that are geographically split by patient service or those in which beds are designated by service. For an example, a facility has an ICU and they call it 5 West, comprised of approximately 50% neurology patients and 50% neurosurgery patients. Additionally, the neurology patients are housed in beds 1 through 10, and the neurosurgery patients are housed in beds 11 through 20. Facility creates 2 new locations in NHSN, named like 5 West North for neurologic critical care, 10 beds, and 5 West NS for neurological critical care for 10 beds. And the advantage to this is by separating this unit into two in NHSN, all data will be collected separately and obtain rates and standardized infection ratios for each location. The mixed acuity unit. This location is intended for those units comprised of patients with varying levels of acuity. Because of this range of risk in these units, CDC does not have plans to publish national pooled mean rates for this location type. Thus, will not be able to compare your mixed acuity unit rates to an NHSN pooled mean, nor will this data be included in any SIR analysis. So I also want to add to this slide, there are several examples to further assist you with decision making. And a master list of CDC locations and description chart is also in this document. Moving on to the annual facility survey. First of all, I want to remind everyone or share with you that NHSN states do not complete your 2014 annual facility survey until after the NHSN January 2015 update is completed. Just one second. If you complete your survey prior to the January 2015 update your work will be deleted. Then you will have to redo the 2014 survey. So regarding this, NHSN will send reminder emails prior to January 1, okay? So this year, the annual survey will include two new sections of questions. There's going to be one for infection control practices and another section for antibiotic stewardship practices. The questions for infection control related to your facility, the first one is infection control practices to gain better understanding of current practices and identify areas to target prevention efforts among your facility's reporting MDROs. And then the second, this information will share what future efforts to improve implementation of recommended prevention measures to prevent the spread of MDROs at your facility. For the antibiotic stewardship questions, first they want to obtain current information regarding your facility efforts to improve antibiotic use and assess the quality of antibiotic stewardship practices. The second, this information will share what your future efforts are to improve implementation of best practices to improve antibiotic stewardship practices and antibiotic use in hospitals. It's recommended by NHSN for facilities to review these questions when the updated NHSN forms and tables of instructions are posted to the NHSN website later this year. These changes will be made to the updated surveys for 2014, which will be part of the January 2015 update. Please remember to wait for the January 2015 NHSN update completion prior to completing your 2014 annual survey. So this work will not have to be repeated. Here are the two references used for preparing this presentation. The first one would be for the actual manual, and then the second one was the newsletter that I got from NHSN website. Thank you.
Thank you, Sherry. That was very good. Thanks for doing that for us.
You're welcome.
Carol, do you have the results of the last polling question? How prepared is your facility for the 2015 NHSN changes?
Yes, Bud. We sure do. I think everybody can probably see in their window that 5 people responded that they were 100% prepared for the upcoming changes. The majority of responders, however, 28 responded that they were 75% prepared, followed by 15 who reported that they were about 50% prepared.
Well, I'm very impressed, and I'm glad that more than less are prepared. Are there any questions right now in the chat box?
Deb, I'm not seeing any questions posted in the chat box at this time.
All right, Erin, can you open up the lines and explain to our participants how they can ask questions? And we'll take a couple minutes right now to see if there's any questions about these 2015 changes.
Certainly, the floor is now open for questions. If you do have a question, please press the number 7 on your telephone keypad. Again, that's the number 7.
So participants can ask on the phone, or you can type in your questions, and Carol will let us know what they are. So I'll give you a minute or two to see if anybody has any questions.
We do have a question on the line from Debbie Malia-Rogers. Excuse me. Debbie, go ahead.
Yes. In the beginning of the presentation, the first one, you mentioned that it was hospital acquired if it was on the 3rd day. I think in the past it's been after the 3rd day, so it occurred on the 4th day. Did I understand that right?
I'm going to let Andrea answer that question. Andrea?
Hi, Debbie. I took the definition right from the NHSN newsletter, and so just to quote myself on the slide, if I said something orally that was different, I apologize, but if we're talking about the admission date of inpatient location being day 1, and the infection with date of event on or after day 3 is an HAI.
So you're saying on day 3?
Yes.
Maybe I misunderstood. I guess I was thinking of, okay. All right, let me think about it. Thank you.
Okay.
Thank you, Debbie. Are there any other questions on the line?
We also have a question on the line from Rita Tanner. Rita?
Hi, yes. I have a question about denominators for MDROs. And so it looked like if you have inpatient behavioral health, you're not supposed to include those patient days in the denominators for like the MRSA bacteremia and the C. difficile infection because of now other reporting from those areas. And I'm just not familiar with if there's new reporting that's going to occur from inpatient behavioral health or why we're not able to use those numbers.
Thank you. Andrea, can you answer that?
Sure. Yes, this is Andrea. I think one thing that CDC has been trying to do in the last few years as other locations such as inpatient rehab, long-term acute care, and inpatient psychiatric locations have come on for reporting is trying to separate things out from the acute care setting. And I would have to go back to my notes on the reporting requirements for inpatient psychiatric locations to double check. But there is not for 2015 a reporting requirement to report MDRO or MRSA, that is bacteremia, lab ID events, or C. diff. But if in the future there would be, the fact that we're already excluding them from reporting from acute care units will make that change easier. So inpatient rehab facilities and long-term acute care facility locations do have to report. That's a new requirement for 2015 from slide 24.
So that if we get any C. diff tests from an inpatient psychiatric unit, we will not be reporting them then. We won't use their patient days as a denominator, and we will not be reporting any C. diff results from our inpatient psychiatric unit then.
If the inpatient psychiatric unit has a CCN that's different from the acute care facility, and I don't know if that's true for all inpatient psychiatric units or if there are additional qualifications or requirements of that.
Okay, so I just need to check and see if they have a different CCN from the rest of the facility.
Yes, that's the key thing. The CCN, that particular number will let you know which pathway to report.
Okay, got it.
Thank you for that question. It is confusing.
Yeah, okay.
Thank you. Is there any more questions on the line?
There are no questions in the queue at this time.
Okay. Is there any more questions in the chat box, Carol?
Yes, we have a couple of questions in the chat box, Deb. The first one comes from Teresa, and the question is, can you use either patient days or device days for reporting? Teresa, can I ask a follow-up question? This is Andrea. Are you referring to CAUTI reporting or CLABSI or VAE or all of the above? Is your line off mute? Just typing in. While Teresa's responding to that question, do we want to move on? Oh, here she goes. She said all of the above. So the requirements have not changed in that regard. Device days and patient days are, I believe, still both required. But in terms of the denominator for the standardized infection ratio, device days, I'm sorry, I'm just looking at the chat box and getting distracted. Device days is still the key. For ventilator-associated event reporting, there are some specific denominators for that are special for VAE that are not applicable for CLABSI or CAUTI.
So hopefully that answers that question. It looks like we have a couple more questions in chat, and we're going to have to move on. So if we get to the end and we have time, we'll continue to answer these questions. And if not, we will be making a question and answer sheet, fact sheet, and be sending that out to all of the participants after the webinar. All right. I'd now like to move on to our next speaker, who's going to be giving an update on Virginia APIC, and that is Marcia Kemp. So I'd like to introduce Marcia Kemp, the President-elect for Virginia APIC. Marcia is a certified infection preventionist who works as an infection prevention manager at Bon Secours Memorial Regional Medical Center. So Marcia, the floor is yours.
Hi, everyone. The APIC National Organization is a wonderful resource for infection preventionists for continuing education, and it's a resource just to help you with everyday issues. You'll find a lot of information there for things that you face every day in the workplace. The Virginia chapter is a very active chapter. We provide continuing education. We have a fall conference every year and try to do some educational lunch and learn type events. And we represent you in infection control issues on the state and the national level and to national organizations as well. We give input into Virginia state legislation. We participate in governors' advisory groups. I just finished representing us on a advisory group for Ebola on the governor's group. And we represent you as well with CDC groups. We had the opportunity to have a couple APIC Virginia members attend the CDC Ebola readiness teams and be part of those teams. And so things like that we do to represent you. And I think one of the most important benefits from participating with an organization like Virginia APIC is the networking and just building the relationships with other professionals in infection control. So that when you have a problem or you need some help, you have people that you can call and can reach out to your peers. And I know I do that all the time. It's a great group of people. I encourage you to become an active member of APIC Virginia. And you'll see our website listed on the slide. And feel free to contact Sherry Merrick for myself. And thank you.
Thank you, Marcia. Our next speaker is Katie Richards. the Maryland HAI Program Coordinator, who will be updating us on the Maryland Department of Health and Mental Hygiene. So, hi, Katie.
Hi, everyone. So if you go on to the next slide, you can see many of our ongoing activities. I'm not going to go over all of these. It's just kind of there for your reference. I'm just going to provide a few updates. So you may know Maryland is an emerging infections program, or EIP state. So we conduct a number of activities in partnership with the CDC and the 9 other EIP states, all following the same protocols. So in 2011, we conducted the first full-scale HAI and antimicrobial use prevalence survey with the other EIP sites, and 21 hospitals across the state participated. So we will be repeating this survey in 2015, including an added assessment looking at the actual appropriateness of the antimicrobials. I'll be starting recruitment of hospitals early next year, starting with those 21 hospitals that participated in 2011. So I urge you to please consider participating. Moving on, our HAI program is also involved in a number of state-based activities as well. We've been very busy with Ebola, as I'm sure all of you have, making sure that Maryland facilities are prepared to assess patients for Ebola and potentially hold persons under investigation during testing. And lastly, I wanted to mention that November 7th marked 1 full year of CRE being reportable in Maryland. So we really appreciate the cooperation that we've received from Microlabs, and we will be preparing a summary report with a year's worth of data, probably early next year for release as well. So that's all I have. You can skip my next slide, as the Maryland Healthcare Commission is here to present an update on NHSN reporting in Maryland. So I'll go ahead and let Deb turn it over to them.
Well, thank you, Katie. So I'd now like to turn the program over to our partners at the Maryland Healthcare Commission, Teresa Lee, the Director, and Eileen Witherspoon, Health Policy Analyst. So, ladies, the floor is yours.
Thank you, and good afternoon. I'd like to, first of all, say congratulations and welcome to VHQC to Maryland. We very much look forward to working with you and to establishing a strong and collaborative relationship. As you all know, Maryland is a little different from other states in that we have a hospital rate-setting system, and our hospitals in Maryland are not required to report under the Inpatient Quality Reporting Program, which is where these NHSN requirements come from. But they are required to participate in NHSN to comply with our MHCC requirements, and it now includes all NHSN requirements that are part of the Inpatient Quality Reporting Program. So we're very happy to work with VHQC and also to take advantage of the training and the guidance that you're providing through this webinar. I'd like to just update everyone on our newest initiative, which is the new Maryland Healthcare Quality Reports website. The website is a single point of consumer access to quality information on hospitals and other providers in Maryland. And under the hospital guide, we have provided the HAI data, the CLABSI, the SSI data, and the infections information that Maryland hospitals report to us. And if you could go to the next slide, I believe we have a screenshot of the central line associated bloodstream infections data. So I would encourage you all to take a look at the new display of the information. We also plan to, on the private side of this website, establish accounts for all of our infection preventionists so they can go to the website to preview data, and there also will be posting of all notices, any changes that come up. This is a way of communicating better with our infection preventionists as changes come about. So that's all I have for now. This slide provides you with the team that focus on HAI issues here at the Maryland Healthcare Commission, and we're always here to respond to your questions and concerns. And again, thank you, VHQC, for allowing us to participate in this event.
Well, and I'd like to thank you all, too, because with short notice, they were able to participate with us, and this information is really valuable. I've been on that website, and there's just a lot of very beneficial resources and information, and you can spend quite a bit of time there. So I'd next like to introduce Andrea Alvarez to give a brief update on activities at the Virginia Department of Health. Andrea?
Thanks, Deb. We, too, are excited about working with our colleagues in Maryland and hospitals across Virginia in 2015 and beyond. One of the things that we haven't talked about yet today that is new or updated for 2015 are the analytic functions in NHSN. And so in 2015, we'd like to continue to work with healthcare facilities to use data for action. So we can look forward to brainstorming together ways to improve your use of the analysis reports in NHSN and allow you to better use the surveillance data that you're collecting. We, too, are interested in promoting antibiotic stewardship and are very excited about the questions about stewardship that are on the annual facility survey. We'll be working with our Hospital Association and VHQC on prevention projects in 2015, and we will continue to be available to you for technical assistance, for surveillance, and in partnership with our local health department colleagues, are always available for assistance with outbreak investigations and other case investigations. So I'll turn the floor back over to Deb. Thank you.
Thanks, Andrea. So I will give the last update for VHQC. VHQC is the Quality Innovation Network and Quality Improvement Organization for both Virginia and Maryland now. And we hold a contract in these two states to perform improvement work using the triple aim goals of better health, better care, and lower costs, with an emphasis on identifying disparities in health care and, of course, engaging the patients and families in their health care decisions. VHQC is currently recruiting not just hospitals, but nursing homes and physician practices to all work together in providing safe, quality care for patients and the communities. So decreasing HAIs and device utilization, along with our work in improving antimicrobial stewardship, falls under the second aim of better care. So we're currently recruiting providers for the Maryland-Virginia HAI Improvement Network. We're recruiting now through June of 2015. Joining now, however, gives your facility access to VHQC-prepared data reports and VHQC assistance with a baseline needs assessment in order to customize your facility's improvement needs. The fact sheet and the commitment form to join the Maryland-Virginia HAI Improvement Network was included in the invitation for this webinar, but please contact me for more information or to join the network. So I hope that you have all found this information presented today to be informative and useful. I so appreciate the expertise of our speakers that we've had on the line today, and I'm very excited to be partnering with these organizations from both Maryland and Virginia to conduct infection prevention activities in both states. So I'd like to ask each of you on the webinar that are participating today that if you have any ideas for future infection prevention topics, type them in the chat box or put them in the comment line of the evaluation. We really appreciate all of your participation today also. So, Erin, can you open up or please post the evaluation for today's webinar and open the lines for any last questions or comments? And I'd like to remind our audience to please take a moment to complete the evaluation before you leave this event page.
Again, if you do have a question on the line, please press the number 7 on your telephone keypad.
And Carol, are there any more questions? I do see quite a few questions in chat, but are there any that we haven't covered or can cover kind of quickly here?
So I'll just take them in order, since each question is very important. So from Andrea, with regard to the VAE pathogen updates, do you know if CDC, NHSN will compile a list of environmental pathogens such as they do for top organisms or common commensals, etc.? Does anybody on the line happen to know?
Hi, this is Andrea. I did answer that question in the chat box. What I was saying earlier, I meant to clarify that the pathogens that will be excluded are fungal pathogens that are typically community-associated, acquired from the environment. I gave a few examples in my notes. There were 6 that were included in the September 2014 NHSN newsletter, and just to follow up, I would anticipate that in the 2015 protocol, they would have perhaps even more. I don't know if that list of 6 is exhaustive or if there will be more. So I would direct you to the 2015 protocol for additional information.
Okay, well, that's great information, and thank you for the clarification, helping everyone to understand and be on the same page. Do we have time for another question out of the chat box, Deb?
Yep, one more.
Okay, so the next one comes from Karen, and her question is, are psychiatric units the same as behavioral health units by the CDC?
Hi, Karen. This is Andrea. Others are welcome to step in as well, but I'll take the first stab. I would need to see the exhaustive list of unit locations to see what the options are, because offhand I don't know what the difference is between behavioral health and psychiatric, and what the universe of options are for people receiving that kind of care, that category of care. So I would refer you to the list of NHSN locations and that document. I don't remember the chapter number offhand, that gives more detail about the types of patients that are in each of those very specific unit locations. But if anyone has additional information, feel free to type up.
I think at this time that sounds reasonable, Andrea, and we are going to have a lot of things to be working out over the next year. So I do appreciate everybody being on the line and being this involved with it. Jennifer, do you have the polling, or do you have the evaluation ready to post? And please, everyone, take the time to stay on the line for that evaluation. There you go. I also want to remind everyone that this was recorded and it will be available in about 7 days. I want to thank all of our presenters and Carol for manning the chat box. And I want to thank everyone that's on the line today for taking the time to be on the line today. So please answer these questions before you leave, and thank you all, and have a great afternoon.
This does conclude today's teleconference. You may now disconnect.